There comes a time in every successful surgeon's life when one's skill is at its peak, and just when we think life is perfect, a reality check is just around the corner. This incident was mine. Endophthalmitis, the most dreaded of all complications, and a cluster endophthalmitis, potentially career-ending. In such a situation, there is no time to panic. All we can do is take stock and plan what next. First and foremost is patient care. Transfer the case to the uvea consultant or to the vitreoretina surgeon for further management. As the primary surgeon, we must maintain contact with the patient through the entire process. The next step is to call all patients operated 2 days prior and 2 days after the case in question. Once cluster endophthalmitis has been established, the next step would be to inform the chairman of the Hospital Infection Control Committee, or the HIC committee. The committee is a multidisciplinary body which coordinates all infection prevention and control activities in the hospital. Members include physicians, lab technicians, representatives from the OT, the CSSD, as well as the biomedical department. An HIC meeting is called. First on the agenda would be to review the clinical status of the patient. The patient usually undergoes an AC tap followed by intravitreal antibiotics and is closely followed up by the uvea consultant, and if surgical care is required, handed over to the vitreoretinal surgeon. Along with this, we also review staff members to look for any kind of obvious infections among the OT staff. It is time now to look for the cause, and we start with the usual suspects, starting with the operation theatre itself. The operation theatre is temporarily closed during the time of this investigation. Look for obvious signs of seepage, recent maintenance work, etc. Once these are ruled out, the next step is sampling. Samples are taken from the OT wall, floor, AC duct, instrument trolley, OT table and pendant. The swabs are then plated onto blood agar medium. Next in line are the consumables and the equipment. Batch numbers from the patient's chart are collected with regards to the consumables used, and also step numbers for the autoclave and the sterilization review. Samples of the consumables like the Ringer lactate solution and the topical drops are collected for culture. Swabs are taken from the microscope objective, the phaco machine and the IV stand. Samples are also obtained from the phaco machine by backflushing the tubing as well as the phaco probe. We now come to our next suspect, the water supply to the operation theatre. To understand this, we must first understand what systems we have in place. In our setup, we use the reverse osmosis system. It consists of the pre-filter, the reverse osmosis system and the storage tanks. There may be more than one pre-filter used in a reverse osmosis system. In our case, we use 3. The most commonly used pre-filters are the sediment filters. They are used to remove sand, silt, dirt and other sediments. Additionally, a carbon filter is used to remove chlorine. The reverse osmosis membrane is the heart of the system. A reverse osmosis membrane will remove total dissolved solids up to 85 to 90% and particles larger than 0.001 microns, thus eliminating sediments, chemical and microbiological agents. It is essential that water sampling be done properly. The faucet needs to be sterilized before collecting the sample. Flaming the tap is the most effective method of sterilization. Run the water for at least 2 minutes. Water is then collected in a clean, sterile conical flask and transported to the lab for processing. We now come to the next component, the air. The air in an operation theatre environment is handled using an air handling unit. Typically, the AHU components include fresh air or return air ducts, pre-filters, heating or cooling coils, a flexible connector, fan compartment, and eventually a supply duct. The air from the supply duct passes through high-efficiency particulate filters, known as HEPA filters, before entering the OT. HEPA filters are composed of usually fiberglass fibers randomly arranged. To qualify as a HEPA filter, the air filter must remove at least 99.97% of all airborne particles greater than 0.3 micrometers in diameter. The efficiency of the air handling unit is tested quarterly, or in emergencies in case of a cluster endophthalmitis outbreak, like in our case. In case of any infection, an air sampling is essential. There are two basic methods employed. In case of the settle plate, standard Petri dishes containing appropriate culture media that are opened and exposed for a given time and then incubated to allow visible colonies to develop and be counted. Slit air sampling is an active monitoring requiring the use of a microbiological air sampler to physically draw a known volume of air over and through a particle collection device. When the correct volume, usually 1000 ml, of air has been passed through the sampler head, the agar plate can be removed and incubated directly without further treatment. The DOP test, or the dioctyl phytolate test. Originally intended for the production testing of absolute, that is HEPA filters, this test, generally referred to as the DOP test, introduces an exceedingly dense cloud of submicronic particulate into the dirty side of the filter under test. The clean side is then viewed against a preferably dark background where the slightest seepage of smoke can be clearly observed. We now use laser to detect these smoke particles. Pressure drops across the filter are used to check for filter clogging, and particulate counts of the room are also performed. Once samples are collected from the operation theatre, the water and the air, we move back to our lab where the actual work begins. Samples are incubated for 24 to 48 hours, and any growth of organisms is quantified as a colony forming unit. Up to 50 CFU is permissible for continued OT functioning. The fluid samples from the tubing backflush, the phaco handpiece, and the consumables like Ringer lactate, topical drops, etc. are plated separately. Water samples are tested using presumptive tests for coliforms. Absence of gas at the end of 48 hours is considered negative. In case of a positive test indicated by turbidity, a confirmatory test is performed by subculturing this sample onto McConkey agar. Water cultures are then isolated as most probable number per 100 ml. The samples from the AC tap are plated on blood agar, chocolate agar, Sabrot's dextrose agar, and smears are also made for gram staining and KOH mount. Now that we know what is to be done, we come back to our case in point. In our case, 24 hours later, our AC tap culture plates showed polymicrobial growth of coliforms and alpha hemolytic streptococcus. Broth from the sample of the Ringer lactate showed turbidity, suggesting the presence of a coliform organism. This was then subcultured to demonstrate the organism matched the organism growth from the AC tap culture. The source was therefore confirmed, the Ringer lactate solution. Once the source was identified, the entire batch was recalled and a complaint letter was drafted to the manufacturer. The OT was also reopened once one set of cultures were negative. All is well that ends well, and our patient showed good signs of recovery. After all, if we follow a systematic approach, it's elementary, my dear Watson.